Welcome to the podcast, Dr. Jean.
Thanks so much for having me.
Yeah, so I'm very excited to talk about this topic, which actually you don't really hear a lot of people talking about, which is how to preserve your fertility if you're going through a cancer diagnosis and if you have to go through treatments, because obviously that can impact a lot on fertility. I have seen actually like a colleague of mine go through it, and she also preserved her fertility, and now she has a baby boy, so it's really nice to
That's so
see.
nice.
So I'd love for you first to introduce yourself and kind of give us a background on how you got into this work.
Of course. So I'm Dr. Nirali Jain. I am an OBGYN by training, and then I did an additional, after completing 4 years of residency in OBGYN and getting board certified in that, I did an additional training in reproductive endocrinology and infertility, or otherwise known as REI. So now I'm a fertility specialist. I trained at Northwestern in Chicago. So I went to undergrad and medical school there. And then home has always been New Jersey for me. So I moved back out east to New Jersey. I did all my training actually in New York City at Cornell for residency and NYU for fellowship. And then moved to the suburbs. And now I'm a fertility specialist in Basking Ridge at Reproductive Medical Associates.
Very impressive background. That's awesome.
Yeah.
So I'd love to hear just really about what your process is if a person has been diagnosed with cancer. Like, what is the process? What are some of the things that you address if they are trying to preserve fertility? And what are some of the concerns going through it?
Yeah. All great questions. So, there's a lot of us, the REIs are there's a very small number of us. So in terms of specializing in fertility preservation, technically we all are certified to treat patients with cancer and kind of move them through fertility preservation before starting chemotherapy. Luckily, we've been working closely with oncologists in the past several years just to establish some type of streamlined system, because having a diagnosis of cancer and hearing all that information, especially when you're young, is so hard. So I think that's where my interest started in terms of being able to speak to and counsel cancer patients. I think it is a very specific niche that you really have to be comfortable with in our field. So I'll kind of walk you through, what does it look like, right? You go into your oncologist's office suspecting that you have this lump. I'll take breast cancer, for example. It could really be any kind of cancer. But breast cancer in a reproductive age patient, or someone that's in those years where you're starting to think about building a family, planning a family, or if you have kids at home, that's usually the type of patient that we see come in with a breast cancer diagnosis. So kind of just taking that, for example, the minute that you're diagnosed, it's really your oncologist's responsibility to counsel you on what treatment options are going to be offered to you. And then based off of the treatment options, it's important to know how that affects your reproduction. So how does it affect your ovaries in the short term, in the long term, in any way possible? So once a patient is initially referred from their oncologist to myself or any other fertility specialist, they come into my office and we just have a 30-minute conversation, really talking about family planning goals, any kids that they've had in the past, either naturally conceived or through IVF. And then we talk about where they're at in their relationship. Are they married? Are they not? Are they with a partner, a male partner, a female partner, whatever it might be? It's important to know the social standpoint, especially in this sensitive phase of life. So patients usually spend anywhere from 30 minutes to an hour just kind of talking through where they're at, how they're feeling, what their ultimate childbearing goals are. And then from there, we do an ultrasound. And that's when I'm really able to see, the reproductive status. So what do the ovaries look like? What does the uterus look like? Is there something that I need to be concerned about from a baseline GYN standpoint? And all of those conversations are happening in real time. So I think one of the things is patients come in and they're like, I'm already so overwhelmed with all this information from my oncologist. And now my fertility specialist is throwing all this information at me. Luckily, the way I like to frame it is you come in and you just let go. Like, you let us do the work, because in the background, we're the ones talking to your oncologist. We're the ones giving that feedback and creating a timeline with your oncologist. And really, I think just getting in the door is the hardest part. So once patients are here to see us, we go through the whole workup. We do anything that we would do for a normal patient that came in for fertility preservation. And then based off of where they're at in their journey, we talk about what makes sense for them, whether that means freezing embryos, freezing eggs. They're very similar in terms of the few weeks leading up to the egg retrieval. So I have that whole conversation just at the initial visit. And then from there, we talk about the timeline behind the scenes and make sure that it works with their lives before moving forward.
So for people listening to this, why, and this might be an obvious question, but to some it might not be, why would somebody want to preserve their eggs or sperm? Because I've had actually some couples that have come to me where the husband preserved the sperm and they had to go through IVF just because he was going through cancer treatments. So he had to preserve the sperm ahead of time. Why would people need to consider doing that before doing cancer treatments?
So there are certain cancer treatments that do affect the ovaries and the sperm health. And, for men and women, it affects your reproductive organs in a similar way, depending on the type of chemotherapeutic agent. There are some that are more dangerous in terms of being toxic to your ovaries or toxic to your sperm. And those are the instances where we are really thinking about what's the long-term impact. Because there's medications that oncologists do give patients, and our oncologists are amazing. The ones that we work with, Memorial Sloan Kettering from Reproductive Medical Associates through RMA. And they're just so good at what they do and are so well trained. So they know in the back of their mind, is this going to impact your ovaries or your sperm health or not? And I think that any chemotherapy, your ovaries are these small organs that are constantly turning over follicles every month. So every month we're losing those eggs. And if an egg isn't ovulated, it doesn't become a baby, it's just going to die off. So I counsel even patients that don't have cancer, I counsel them on fertility preservation as young as possible, between the ages of 28 and 35. That's like the best time to preserve your fertility. So in cancer patients, there's an extra level added to that where even if they are a little bit younger, a little bit older, your eggs are not going to be the same quality. There's going to be higher level chromosomal errors, more DNA breakage, and bigger issues that lead to issues with conceiving naturally afterwards. So I think that it's important to consider how that chemotherapy is going to affect them or how a surgery would affect them if it was, for example, a GYN cancer where we're removing a whole ovary. What do we have to do to preserve your fertility in that case? And those are important conversations to have.
Yeah, for sure. I know that a lot of people are also concerned, with going through the IVF process, you're taking in a lot of estrogen, a lot of hormones, and many cancers are actually estrogen sensitive. So I wanted to talk to you about that because I know that the data shows that it's been fine, which some people might find surprising, but I wanted you to address that and just kind of talk about it from your perspective.
That's so interesting that you asked that question because I graduated fellowship last year and my entire passion project in fellowship was looking at one of the drugs that we use to suppress the estrogen levels, specifically in cancer patients. And I had presented this at a few of our reproductive meetings. ASRM is one of our annual meetings where all of the REIs get together. A lot of male fertility specialists come and we kind of just talk about specific things, and fertility preservation for cancer patients has been an ongoing topic of interest for all of us. And it's important to know that there are different medications that we can offer. Letrozole is the one that I have a particular love for, and I use it all the time for my patients for different reasons. But it suppresses the exposure that your body has to estrogen. And there's mixed data out there in terms of, does letrozole suppression actually impact, does it help or does it have no impact on your future risk of cancer after treatment? And that honestly is still up for debate. But what we do know is that there's no increased risk of cancer recurrence in patients that have undergone fertility preservation with or without letrozole. Letrozole is one of those things that we can give, and the way it works is basically it masks that conversion. It doesn't allow for conversion from those androgens and the male hormones over to estrogen. And so your body doesn't really see that estrogen exposure. It stays nice and low throughout your cycle.
Mhm.
And it does help with actually ovarian maturation and getting
Yeah.
mature eggs harvested, and it helps a little bit with quality too. So I think that it's really nice in terms of having that available to us, but know that it's not essential that you have it. Really, the data is showing plus minus. But there are certain things that we can do to protect the ovaries, protect your exposure to estrogen. And so that shouldn't be top of mind of concern when you're going through fertility preservation, even with an estrogen sensitive cancer.
Actually, so on a different topic, kind of going back to that. So letrozole versus Clomid. It's like the questions. I personally feel, just based on what I've heard and like my own research, that letrozole would be kind of like the more it's a little better, but I know that it really depends on the person as well. In
Yeah.
certain circumstances, they might do better with Clomid, but I'd love to hear your perspective and kind of
Totally.
pick your brain on this.
Totally. You're choosing all the right questions, because these are all of my specific interests and niches. So
Oh, awesome.
letrozole is basically, we use letrozole and Clomid in patients that don't have cancer and patients that come in for an intrauterine insemination. That's kind of the most common scenario where we're thinking about, which medication is better, letrozole or Clomid. And Clomid used to be the most common medication that we use. We dose patients, 50 milligrams of Clomid, give them 5 days of the medication. It's an oral pill, feels really easy. And the way it works is really it recruits more than one follicle. So it really helps with the release of more than one follicle, growing more than one follicle in the ovary. But it has a little bit higher of a risk of twins, because that's exactly what it's good at. Clomid, not so much in the cancer front. It's not really used there because it's considered, from a scientific perspective, it's considered like a selective estrogen receptor modulator. So it doesn't necessarily suppress your estrogen levels in the same way that letrozole does, versus letrozole is an aromatase inhibitor. So it really blocks the chemical conversion of one drug or one hormone to the other hormone. The reason we love letrozole so much, and I don't mean to like gush over letrozole, but it's a monofollicular agent. So it works really well at recruiting one follicle. And, every OBGYN's nightmare in a way is having multiples when you didn't intend on having multiples at all.
Wait, so when you were saying that there's more of a chance of twins, it's Clomid, not letrozole.
Yes.
Okay, got
There's
it.
a higher chance with Clomid versus letrozole.
Yeah.
And I mean, don't get me wrong, there's a chance of twins with any type of assisted reproductive technology. Even when we're doing single embryo transfers, there's a chance that it's going to split. So that chance is always there, just like it is in the natural world.
Yeah.
But we know for a fact that Clomid is really good at recruiting many follicles. It's good for certain patients that don't respond well to letrozole. But letrozole is kind of our go-to drug these days, just because of all the benefits that we've seen.
Awesome. These are all fun things to ask, because I love talking to our EIs, because there's so much information that I'm always like, I learn a lot from my patients and my own research, but it's really cool picking your guys' brains. So another question I have, and I have actually talked to Dr. Andrea Videlli. He's been on before, and he does a lot of endometriosis and immune related work as well.
Yeah.
So I'd love to know, just from your perspective, one thing that I do know based on what I've heard, is that I guess like you were just saying, that breast cancer or estrogen sensitive breast cancer doesn't seem to be affected by IVF cycles. However, endometriosis lesions do get affected.
Yeah. That's a great question. So, there are so many complex GYN diagnoses that our patients come in with. And endometriosis is a big one, because there is clear data that endometriosis is linked to infertility. So we think about, when a patient comes in with endometriosis, we really do think about the different treatment options and what are the short-term and long-term impacts of the hormones that we're giving them. These days, again, kind of going back to letrozole, letrozole is something that I give all of my endometriosis patients, because it helps suppress their estrogen, because we know
that's interesting.
Endometriosis is very responsive to estrogen and leads to this dysfunctional regulation of all the endometrial tissue that can really flare in a cycle or shortly after a cycle. So we really, for endometriosis patients, the best treatment is being on birth control, because we don't see that hormonal fluctuation, the up and down of the estrogen and the progesterone. That's what leads to those flares. So I watch patients closely after their cycles too, because you definitely can have an endometriosis flare. And we say
Yeah.
the best treatment for endometriosis is pregnancy, right? That's when you're suppressed.
Right.
That's when you're at your lowest. And my endo patients feel so good in pregnancy because they have hormones that are nice in that baseline. They're not getting periods, of course. And that's truly, truly the best treatment.
That's interesting.
But it is important to consider when you're going through infertility treatments, how does my endometriosis affect the short and long-term effects of the fertility medications? And really not to say that they're bad in any way. I think a lot of endometriosis patients go through IVF and have success and do really, really well. And that's kind of the push that they need.
Yeah.
But it's important to be mindful of the bigger picture here. You're not just a number of a patient with endo coming in, getting the same protocol. It's really individualized to the extent of your lesions, what symptoms you're having, what grade of endometriosis, where your lesions are. So
Yeah,
the RAs are thinking about everything before we actually start your protocol.
Yeah, it's crazy how in depth it is, and it's so multifaceted, especially when it's females, because
Totally.
males are a little. I mean, they can, there's definitely a number of things, but it's not as complicated and interconnected as females.
Exactly. That's so true.
And so, question I actually have, this is kind of really off topic, but something that I was curious about because I heard about a while ago. There was a type of cancer treatment that was used. I'm not sure exactly what it was, but for some reason, it actually caused follicles to grow or to multiply. And they were thinking, okay, this definitely puts the whole idea of like a woman being born with all the follicles she'll ever have on its head. And I thought that was really interesting. Now, I learned a little bit about it. I don't think it really went further than that, but it was definitely one of those things that they're like, this is interesting. I don't know. It was kind of a random side effect of this chemo drug. I don't know if it was a chemo drug or a cancer drug.
Yeah.
I don't know if you've ever heard of that. So I was just curious.
I haven't. I mean, that's interesting. I feel like I'd have to look into that because that would be definitely a point of interest for a lot of REIs. Yes. But it kind of does go back to the point of, women are really born with all the eggs we're ever going to have. So it's about 1 million, and then it just goes down from there. And by the time you start having periods, I like to kind of show my patients a chart, but you have a couple 100,000 eggs and you ovulate 1 egg a month that's, able to progress into a fertilized egg and then into an embryo, into a baby, if that's your goal. But otherwise, patients that are having periods and not trying to actually get pregnant, we're losing hundreds of eggs a month. So it's important to kind of think about that decline. And it's important to know that rate can be faster in patients with cancer, patients with low ovarian reserve. And sometimes when you have the two compounded, that's when a fertility specialist is definitely, in the queue to have a discussion with you in terms of what that means and how you can reach your family building goals despite being faced with that challenge.
Yeah, I mean, because we know oxidative stress is one of the things that can cause low quality eggs, but it also can cause cancer. So there's so many similar, like things that really deplete the body that could definitely impact. And then what are your thoughts? I know I'm asking you all kinds of random questions, but what are your thoughts about doing low stimulation in certain circumstances versus high stim? Sometimes people don't respond as well to higher stims.
Yeah. That's a great point. I think that it kind of all goes back to creating an individualized protocol. If a patient's going to a practice and basically just getting a protocol saying, this is our standard. We start with our standard of, I think about the standard, which is 300 of the FSH or that pen that you dial up, and then 150 units of that powder vial. And we have patients mixing powders all the time. And that's kind of our blanket protocol that we give patients. But that's not really what's happening behind the scenes. And if you're given a protocol and being told, this is kind of what we give to everyone, probably not the right fit for you.
Yeah, I agree.
There are certain patients that respond to a much lower dose and do really, really well. And then some patients that need a much higher dose. And I think that's kind of like the fun part of being an REI, of being able to individualize the protocol to the patient. And I know for a fact there's so many, luckily, we have so many leaders in REI that have dedicated their entire careers to researching these different protocols and how they can help different patients.
Yeah.
Patients with lower AMH, might benefit from a DuoStim protocol, for example. It's kind of the first one that comes to mind, but a protocol where we're using those follicles from the second half of a cycle. I would have never thought that those were the follicles that
Oh, that's
would be
interesting.
better than the first half of the cycle.
Wait, so
But
explain that, because I think that that's kind of a unique perspective that I haven't heard of.
yeah, so there's this new data. It's still kind of developing, but kind of going back to, what's an individualized protocol. DuoStim is one of the newer protocols that we started using. I've used it once or twice in patients, but it goes back to the research that shows that you might actually have two different periods of time in a menstrual cycle where you could potentially recruit follicles. You could have a follicular phase where there's a certain cohort of follicles recruited, and then you have a follicle that forms,
which is the typical
luteum.
Protocols are done.
Yep. And then you basically go through the follicular protocol, and then a few days after retrieval, instead of waiting for a new follicular cohort or follicular recruitment from the first half of your menstrual cycle, you actually use the luteal phase, and you recruit those follicles that would have actually died off or have been prematurely recruited in a prior cycle.
Oh, wow. That's so interesting. Yeah. So then you just do a similar, I guess, medication.
Go right back into it.
Just do the same exact thing, but right after ovulation.
Yeah.
Fascinating. That's really interesting.
Yeah.
And what has been your experience with that?
I think it's mixed. So far, our data from fertility and sterility and ASRM, it shows support for these DuoStim protocols, saying that if patients don't have that great quality of eggs, or if they have a very low number, maybe they'd benefit from starting the meds earlier and recruiting follicles a little bit earlier. So we've seen positive results so far. A lot of work to be done in terms of really understanding it. And of course, as a new attending, I have a lot more experience to kind of build on.
Yeah.
But I have seen success from it.
That's fascinating. Are there any other new technologies, like new add-ons, that you've seen that you've found to be really cool or interesting?
I think the biggest thing, actually, kind of going back to our whole topic for today, is fertility preservation in cancer patients. One of the biggest things that I've learned recently is that we used to start fertility patients, only in the beginning of the cycle. Days 2 or 3 is technically like when most clinics start patients. But for our cancer patients, sometimes you don't have that time. You don't want to wait a full month to restart your menstrual cycle and then do the fertility preservation and then delay chemotherapy a full month. So we started doing what we call random starts. So you basically start a patient whenever they come in. It could be the day after your consultation, the day of your consultation. I've kind of seen all of the above. And we've seen really good success with random starts, per se. And we've been doing a lot more of that, where it's not as dependent on where you're at in your cycle. Obviously, there's a difference in outcomes. You might not be a great candidate for it. So definitely it's worth talking to your doctor about it. But it kind of gives relief to our cancer patients, where if you have a new cancer diagnosis and you're like, oh, I just finished my period, like I can't even start a cycle until next month.
Right.
That's not always true. So it's always worth it to go in to see a fertility specialist and just get the data that you need right away, and then you can make a decision later on.
Yeah, for sure. And I wanted to kind of cover a lot of different topics, because I know that some people are going to want to hear what you have to say that don't necessarily have cancer, but it is important. I think that, if you get to 30s and you haven't gotten married or you don't have a partner, I think it's really important to preserve your fertility in general. I think it's an important thing. And then if you were going through a cancer diagnosis and you decided to preserve your fertility, I guess more for women, because they're eventually going to be thinking about transfers after they go through treatment. Yeah. So what are some of the things that they would need to consider as far as that goes? Like after the retrieval, then they go through the cancer treatments. And then what? How long should they wait?
Yeah, what does it look like?
Yeah.
So I've had patients that come back, in my fellowship training, I did a couple of research projects on patients that came back to pursue an embryo transfer after chemotherapy agent, and basically compared them to how they did compared to patients that didn't have cancer and just froze their embryos or froze their eggs and then came back to pursue a transfer. And I think the most reassuring thing from the preliminary data that we have is saying that there's no difference in pregnancy rates and no difference in
Oh, that's
live
great.
births,
Awesome.
regardless of whether they had chemotherapy or not after freezing those eggs and going through fertility preservation.
Amazing.
In terms of where your body needs to be, I think the oncologist, we wait for their green light. We wait for their signal to say, she's safe to carry a pregnancy.
Mm-hmm.
And then once we do that, we basically treat you like any other patient. So if you're coming in for a cycle, if you're having periods, then it's reasonable to try a natural cycle protocol, wait for your body to naturally ovulate an egg. And instead of obviously hoping that egg will fertilize, we use the corpus luteum. We use the progesterone from the corpus luteum to really support this embryo being implanted into the uterus. And then there's also another side. I mean, some patients don't get their periods back. And they always ask, like, what if I never get my period back? What if I'm just like in menopause because of the chemotherapy agents? And for that, we can start you on a synthetic protocol or basically an estrogen dependent protocol where you take an estrogen pill for a certain number of days. We monitor your lining. Then we start progesterone to support your hormones from that perspective instead of relying on your ovaries to release the progesterone that they need. And then doing the embryo transfer a few days after progesterone starts. So there's definitely different protocols depending on where your menstrual health is at after the chemotherapy or after the cancer treatment. But it's important to kind of just know that there's options. It doesn't mean that it's the end of the road if you all of a sudden stop getting your period.
Yeah, for sure. I mean, because technically speaking, you can really control a lot of that more so for transfers than retrievals. Retrievals really is kind of like what eggs you have, what the quality is. But people can be in complete menopause and you guys can still control their cycles for transfer, which is kind of a huge difference.
Yeah.
In the phases.
Exactly.
Yeah.
That's exactly right.
So interesting. Any other new things that you guys are excited about? I always like to hear about like the new and upcoming things, like you just mentioned actually before, which I thought was fascinating.
Yeah, I feel like there's always like updates and new data and things like that coming out. But just know, I think it's important for patients to know, like the reason I chose to even pursue this field was because it's new, right? There's something that we're discovering every day, every year. And that's what makes our conferences so important to attend, to really just stay up to date. But we are constantly updating our embryology standards, the way we thaw our eggs and the success rate associated with a thaw and how we treat our embryos and the media that we use, right? Like, so we're really thinking about the basic science perspective every single day. And that's what makes this field so unique.
It is really awesome. And so do you guys specialize specifically on egg freezing and I mean, specific fertility preservation in patients that have cancer that are going through treatment? Do you guys specialize specifically in that? I mean, I know you do a range of things.
Yeah, because it's such a small community, we all have our own niches and we all kind of have our own interests. And there's no like specific training. There are a couple courses that you take that I took in training as well, just to kind of understand what it sounds like to counsel a fertility preservation patient with and without cancer. And then, you kind of just learn by experience and you form a niche for something that you're passionate about because that's what makes you, really thorough in your treatment. So that's one of my interests.
Got it. So there's no like specific training for that. It's just like, you just know how to treat that in that situation, especially if you're interested in doing that.
Exactly. That's exactly right. It just comes with the experience, comes with your mentors and who you're surrounded by, and everyone kind of helps each other get to that point. But there are several specialists in our practice at RMA that specialize specifically in fertility preservation in cancer patients. So we have a close communication with our oncologists and they know who to refer to within the practice because everyone has their own little interests.
Amazing. So interesting. Definitely, like I said, I really enjoy picking your brain because it's a lot of fun for me. I do fertility acupuncture. So it's kind of, and I think that it's just so crazy that our fields don't work together. I mean, we kind of do, but I just feel like it would be so great to combine the expertise, because you guys have immense benefits, like in technology and incredible innovations, and then the natural aspect of really understanding the body. And I just think that it would work so amazing together if it was more of like a thing, because I know in China they actually combine the two, Western and Eastern.
Yeah, I mean, I think that that's so important. And there is data that shows, there's actually a recent study that came out just a few weeks ago on the benefits of acupuncture for fertility patients. And we know that, I mean, I recommend it to all of my patients, specifically the day of the embryo transfer. Luckily we offer it on site at
Yeah.
RMA, and
Hmm.
we have acupuncturists that come in and do a session before and after the embryo transfer. And I think a lot of that is targeted towards stress relief, but I also think that holistically, it's important to feel at your best when we're doing something that's so crucial to your health. So to really focus on the diet, focus on stress relief, focus on meditation, yoga, whatever it takes to get to your best well-being when you're going through fertility treatments, is so important. So I appreciate people like you that really specialize in the other side of this, because I do consider it still part of the holistic medicine that we need to really maximize success for our patients.
Awesome. Well, Dr. Jain, this is such a pleasure talking to you. You've given us so much great information, and we've definitely dived into a topic that I haven't yet spoken about. But that being said, it's such an important topic to talk about. And thank you so much for coming on today. Oh, before I get off, how can people find you?
That's a great question. So I have a social media page. It's called Expert MD, so like EGG.
Love that.
Expert
That's
MD.
great.
Tried to make it a little bit humorous, but I'm all over social media and would love to hear from anyone that is listening. Every day I get different DMs, and I'm happy to respond. I love hearing about everyone else's stories and things like
Awesome.
that. So that is kind of my main social media platform. And then through like RMA and Reproductive Medical Associates, we also have a YouTube channel. We have an Instagram page of our office available as well that is public. So you can find us pretty easily if you just kind of hit Google. But yeah, I'm kind of developing my social media platform as the expert, and I hope it grows.
Love that. Great. Well, it was such a pleasure talking to you. Thank you so much for coming on today.
Of course. Thank you so much for having me.